All right, welcome back to The Breakfast Show, the show worth waking up for. I am, of course, with the lovely and talented Aisha Sinclair. And I'm JP.
Thank you so much for that introduction, JP. I wasn't expecting that. Anyway, as promised, we'll be talking about cochlear implants, which is an implant to help, or a device to help severe to moderate people with severe to moderate deafness, especially youngsters out there. We've got a pretty interesting story that we could actually tell later. So joining us here on set, we've got Dr. Arasa Raj Sinatre, who is the ear and nose throat consultant specialist or surgeon at Gleneagles, Kuala Lumpur. Good morning. Welcome to the show, Dr. Arasa. Thank you so much for joining us.
Thank you for inviting me.
So, yeah, I just said that a cochlear implant just helps people hear again. So could you probably tell us a little bit more about that?
Yeah, I mean, this is basically the device here.
Okay.
It takes over the function of the inner ear. So basically, in a child or adult where the inner ear function is close to completely gone, and a hearing aid would normally stimulate the inner ear, and the sound gets transmitted to sort of nerve impulses. But in a situation where the inner ear is not really working, then a hearing aid won't work. They get a lot of distortion. So what the cochlear implant does is this fine electrode is inserted into the inner ear, and it directly stimulates the nerve endings.
So this, when you talk about the electrode that's inserted into the inner ear, we're talking about this.
Yeah,
the little tail.
The little tail. I don't think you can see it. Okay, there you go. It's this little.
Yeah, it's about half a millimeter.
I will use. I use the dark. You know.
Yes.
Yes. Probably you can see it. Counter. There you go. So this is a little part that's inserted into the ear. Now tell us what's this and where does this go?
Okay, that's placed under the skin on the skull behind the ear.
I see, right
so,
back there. Yeah.
And outside you have a little disc which has a microphone in it and a processor to convert the sound into electrical signal. And then this magnetically attaches to this. Through the skin. So the information goes into this called a receiving coil, and then this this modulator here will change that information into electrical signals which can stimulate the inner ear. So it's got very sophisticated processing mechanisms, much more than a hearing aid would.
Right.
Because it has to convert the acoustic energy into electrical signals.
Correct, for the brain to
interpret. The hearing
interpret.
aid converts acoustic energy into more acoustic energy. It amplifies sound.
Right,
It does more than amplify sound. And it works across the frequencies. And it's very good for the high frequencies because most people tend to lose the high frequencies first. And the hearing aids tend to fall short on the high frequencies.
Yes.
So much so that the new cochlear implants are able to selectively amplify the high frequencies in patients where they've still got some low frequency hearing.
Right.
So you can combine acoustic signals with electrical signals. The advantage being the acoustic signal for the low frequencies gives them better appreciation of music and tone intonations.
Correct.
You know, especially like in Mandarin, for example, I believe different intonations of the same word.
Right.
So, and that's called an electroacoustic implant, where it's combining electrical with acoustic signals. It's just basically a shorter electrode.
Right.
The electrode goes into a shorter extent. So this works for patients with severe to profound deafness or for patients with selective high-frequency deafness, and it's semi-implantable. And you can implant one side or both sides. The advice for children nowadays is bilateral, two-sided implantation, because it helps in situations like in a noisy classroom, because the noise tends to mask the implant if it's on one side, and then they don't have any hearing on the other. So, because we hear with 2 ears, so in the noisy situation, we're quite dependent on the opposite ear to where the noise is coming from.
Right.
So that's one. And localizing sound, we depend on the 2 ears to work out
where's it coming
the
from,
timing,
distance.
the different timing between the 2 ears and different intensity. And the last thing is it's more to do with adults. If there's someone sitting on your what we call the dead ear side, if you've only got one implant, for example, it's very hard to pick up the sound, especially the high frequencies. So they're recommending for children nowadays 2-sided implants, but there's a cost factor and so forth.
Of course, of course.
Now, you mentioned briefly that you touched on the differences between a hearing aid and you know, this kind of cochlear implant.
Yep.
Would you be able to expand a little bit on that? You mentioned that the cochlear implant is more of a converter versus an amplifier.
Yeah, a hearing aid has a microphone which receives the sound. It has got a processor which tries to selectively amplify the bits that the patient is deficient in.
Right.
But the sound comes out through a loudspeaker. So it brings in acoustic sound and it delivers acoustic sound and it sits in the ear canal. So it stimulates the eardrum. And it's depending on the inner ear, which is beyond the eardrum. Because you have the ear and the ear canal, which form the outer ear. You have the eardrum, and there are 3 bones behind the eardrum, which basically transfer the sound or conduct the sound from the environment into the inner ear, which is encased in bone. So the bit where the 3 bones are is called the middle ear. And the inner ear basically is fluid-filled. It's a fluid-filled shell. So when the 3 bones vibrate, there's a little window which it stimulates, and this movement of fluid is detected by little hair cells, which change it into electrical signals, which the nerve picks up. So you've got the outer ear, middle ear, and inner ear. And a hearing aid depends on a working middle ear to a certain extent, but certainly a working inner ear to be able to make this conversion. Because it's quite sophisticated to change acoustic energy into electrical signal. Whereas a cochlear implant is directly stimulating the nerve endings of the hearing nerve. So it bypasses the cochlea.
So it directly informs the nerve receptors what you're hearing, as
Basically,
opposed to just being a headphone that amplifies the sound.
Okay. Now, what's the minimum or maximum age that a patient can actually undergo this treatment?
The key thing in children is to diagnose the hearing loss as soon as possible. So babies should really undergo a neonatal screening issue. All children really should. And it's a simple yes-no test. And if there's a no, then there's a sort of a more sophisticated hearing test. And then hearing aids should be put on a little newborn, really, to be honest.
Okay, but how about a cochlear implant? Would you be able to...
No, we don't do it so young. The idea is to get the sound into the brain as early as possible.
So
But the skull's not quite thick enough to receive it. So around a year plus is the sort of suggested age. Some centers in the West are doing it a bit earlier, but a year to a year and a half is a sort of a good age to get the implant in.
And you'd use this exact implant, or is there a smaller version?
No, it's the exact implant.
It's the exact one. And you don't need to, change it throughout years?
You see, the wire is quite long, so this is coiled in the bone here. We create a little cavity here between the bit under the skin and the inner ear. So as the head expands, the wire also expands. So this bit's fixed in the cochlea, this bit's fixed in the skull, so they don't need to change it. Theoretically, it should be lifelong. And there's no upper age limit, whether you're 80 or 90. Basically, if you can't hear, you're disabled.
Yes.
So...
Now, there is a story, a patient, a 12-year-old, who actually, got herself a cochlear implant and could hear the world for the first time. Tell us a little bit about that story, the story of Nitya Priya.
Yeah, this girl was diagnosed at the age of 2. And unfortunately, due to a variety of issues, she didn't get a hearing aid till she was 11 and a half. So for 9.5 years, she had, and she had close to profound deafness. There was perhaps a tiny bit of hearing in the high frequencies in 1 year. And when she came to me, she had no words. She just got her hearing aids when I'd seen her. I can't remember if she got them just beforehand or after seeing me. And with the hearing aids, she could just about pick out a car horn, just about. And then the issue was her age, because the implants, we have to hear to learn to speak, basically. And the brain tends to mature so that around 8, 9, 10, it becomes quite difficult for the brain to understand what sound means if it hasn't got it, which is why they have the neonatal screening program. But this girl had practically no speech, maybe 1 word, and she appeared motivated, intelligent, bright, The mother understood that the outcome was not going to be as good as a child that was implanted early, and this was our only chance, okay? So I told them, look, her hearing will probably improve, but her speech is going to be very slow, and pretty much that's what's happened.
Right.
So her hearing sort of jumped about 50% up the scale. From a situation where she could just about hear a car horn with a hearing aid to where now she can hear a range of words without lip reading. Right. And her speech is now 2-3 words from one word, a vocabulary of one word. Now she can make not full sentences. So her speech has only jumped by about 25%. And it's pretty much what I said to the mother. It's going to be slow. So she's got the speech of like a 2-year-old. And she's got the hearing of maybe like a 3-year-old. And so she's behind by about 9-10 years. And it's going to take a lot of speech therapy and auditory training. So it was basically that, or she's going to have to learn to sign. Right. So it was a no question.
Well, I think what we can take from that story is the importance of early intervention. Once you know the results of the neonatal testing comes out, you know, an ENT specialist is the first person you should see. Anyway, thank you so much, Dr. Arasa, for telling us a little bit more about the cochlear implant. Dr. Arasa practices at Gleneagles, so you know if you know where to look for him.
Absolutely.
If you need to make an appointment.
If you have any questions or concerns further beyond today's interview or whatever, you can feel free to consult ear, nose and throat specialist, or you can consult the doctor himself and find a little bit more about how you can help yourself or your children should they be having any difficulties hearing.
Anyway, thanks again, Doc. We're going to take a quick break here on The Breakfast Show, but coming up next, yes, we talk about the Danny Crow Show.